name's Judy, and we're going to be doing some knee x-rays today. So the first three projections that we're going to be doing of the knee are the AP projection, the AP oblique with medial rotation, and the lateral. For all three projections, we'll be using the same technique, and it's going to be a ballpark between 65 to 70 kVp, about 8 to 10 mass, depending on the size of your patient. We'll also be using a 10 by 12 IR size for all three projections as well. We'll be using the table bucky. And I'll start setting my room up before my patient gets here. I will detent my tube to the table at a 40-degree SID. I'm going to wag the tube out of the way to get the patient. Also, for all three projections, we'll be using a 5-degree cephalic tube angle. According to Merrill's, this tube angle will change, especially for the AP projection of the knee, depending on the measurement of the patient's as-is to the tabletop. However, at this clinical site, we do a 5-degree cephalic tube angle for all three projections. Now that the room is set up, we'll go get our patient. Hi, how are you? Good. I'm Judy from the X-ray department. We're going to be doing some X-rays today. Can you tell me what your first and last name is, please?
Denise Carvel.
Okay. And your date of birth?
8992.
Okay. And is there any chance that you could be pregnant?
No.
All right. So what brings you in today?
I fell playing soccer.
Okay. So we're going to be doing some knee X-rays. Which knee hurts?
My right knee.
Your right knee. Okay. And when did this occur?
A week ago.
A week ago? Okay. So come on in. You can take a seat on the table and lay down. Okay. So it seems that these pants are okay for the X-ray. However, if this was a real patient, I would probably move the pant leg up to expose the knee. I'm going to So now I'm going to be checking my tube angulation, making sure that it has a 5-degree cephalic angulation and that it is lined up with my IR. Okay. Now that the tube is detented and ready to go, I will be moving the patient on the table. I also said it was her right knee, which matches what's on my paper for her. I'm going to be palpating for the apex of the patella, where the central ray will enter ½ an inch below the apex of the patella. I will then collimate in. And I do want to make sure that I get a little bit of the femur as well as a little bit of the tib fib. I will be marking my image. And then we will also be shielding our patient. Here. Sure everything looks good. Okay, so this is the AP projection. Okay, don't move. X-ray. Okay, so now we're going to do the next projection. So I will take this one out and I will be switching my IR. Same orientation, portrait, 10 by 12. Now for this projection, I'm going to have the patient log roll their leg internally at 45 degrees. The central ray will also enter half an inch below the apex of the patella. I also will collimate on both sides and down. Making sure that my image is also correctly marked. The internal oblique rotation. Okay, same technique, X-ray. All right, so the next projection is going to be the lateral projection of the knee. So we've asked our patient to roll over onto the affected side, which in this case is the right knee. We have shielded our patient and had them comfortably rest themselves with the unaffected side in front. You can also do it in back too, whatever's comfortable for them. For this projection, we're going to have the CR 1 inch distal to the medial condyle. We want the condyles perpendicular to the IR. We also want to collimate down. And of course, mark our image. All right, same technique, 5 degree cephalic tube angle. All right, Scarball, don't move, X-ray. Beep. All right, now that we've done these first 3 projections, I'm gonna go ahead and run these in the reader and make sure that these 3 came out okay before moving on to the next 2 projections. Now that we've reviewed our first 3 images, we can move on to our next image. This is called the AP axial projection of the intercondylar fossa. It's also known as the Baclair method. So we are still shielding our patient. We have asked them to flex their knee approximately 60 degrees. We're also using an 8x10 IR, which we have built up underneath the knee. We have angled our tube perpendicular to the long axis of the lower leg, and our central ray is also entering a half an inch below the apex of the patella. We've collimated in just around the knee, and we will appropriately mark our image as well. So because this is a tabletop projection, our technique is going to change from the first 3 images. So this will range between 60 to 65 kVp from 4 to 6 Mass. All right, Ms. Carvajal, stay still. X-ray. Okay, now on to the next image. All right, so now we're on to our last and final projection. This is the tangential projection of the patella. We have our patient supine and shielded. We've asked them to flex their knee, and we have angled our tube 15 to 20 degrees depending on the flexion of the knee. In this projection, we are going to have our patient help us. So I'm going to turn the lights down here just so we can get a more clear image. So, all right, Ms. Carvajal, please hold this. So this is also a tabletop projection, so we are going to be using the same range of technique as we used on the other projection, so 60 to 65 kVp, 4 to 6 Mass. So we want to make sure that we have the whole knee in the shadow here in the center of the IR. I'm going to collimate down just a little bit. I'm going to make sure, here we go, that it's in the center. I'm also going to mark my image. And the central ray is going to be entering perpendicular to the patellofemoral joint. Okay, so just hold still. We're going to go ahead and take this projection. X-ray. All right, and that was our last projection. So we're going to go put this in the reader and make sure everything looks good. So this here is a diagram from Merrill's, and I just wanted to show how we decide what kind of tube angle goes on our tube for the AP projection of the knee, depending on the measurement from the patient's as is to the tabletop. So as you can see here, an 18 centimeter and below gets a 5-degree caudate angle. This is mostly used for children. This is more the normal sized adult patient, 19 to 24 centimeters, and therefore Merrill suggests a perpendicular tube angle. For a heavier set patient with a 25 centimeter and above measurement from the as is to the tabletop, a 5-degree cephalad tube angle is recommended. However, we did use a 5-degree cephalad tube angle for all of our projections, as these do vary from clinical site to clinical site. All right, so this is the image, the AP projection of the knee. And as you can see, here's the evaluation criteria from Merrill's listed on the side here. There's evidence of proper collimation and the knee is fully extended. That is, however, if the patient's condition permits. The entire knee is also shown without rotation, and we can tell this because the femoral condyles are symmetric and the tibia intercondylar eminence is centered. There's a slight superimposition of the fibular head, and the patella is completely superimposed on the femur. As well, there is an open femoral tibial space, and the interspaces are equal width on both sides if the knee is normal. Next, we have the AP oblique projection of the knee with medial rotation. One of the best ways to see whether this is an internal or external rotation is to look at the patella. As you can see, the patella is on the medial side of the femoral condyle. There's evidence of proper collimation. The tibia and fibula are separated at their proximal articulation, right here. You have posterior tibia. The lateral condyles of the femur and tibia are also shown, as well as both plateaus, tibial plateaus. The margin of the patella is projected slightly beyond the medial side of the femoral condyle. That's what we spoke about a little earlier. The knee joint is open, and there's good soft tissue and bony trabecular detail. So this is a good image of the AP oblique projection with medial rotation. Next, we have the lateral projection of the knee. There's evidence of proper collimation, and the knee is shown in a true lateral position. It's in a 20 to 30 degree flex position, and the femoral condyles are superimposed. The fibular head and tibia are slightly superimposed, and the patella is seen in lateral profile. The patellofemoral joint space is also open, as well as the joint space between the femoral condyles and the tibia. And again, we have good soft tissue and bony trabecular detail. Next, we have the Beclaire method. This is an AP axial projection of the intercondylar fossa. The most important evaluation criteria here is that the intercondylar fossa is open. So we want an exaggerated open intercondylar fossa space. We also want to see the posterior surface of the femoral condyles and the intercondylar eminence and knee joint space, which is all in here. And we also want no superimposition of the fossa by the apex of the patella, and there should be no rotation as demonstrated by a slight tibiofibular overlap right here. And as always, good soft tissue and bony trabecular detail. So here we have the tangential projection of the patella and the patellofemoral joint. This is also known as the sunrise projection. There's evidence of proper collimation, as you can tell that the patella and the knee only occupies this small area. The patella is in profile. The femoral condyles and the intercondylar sulcus are seen. The open patellofemoral articulation is also clearly seen, and there's good soft tissue and bony trabecular detail.